A surgery recommendation can sound like a green light, but after 65 it should really sound like the beginning of a very important conversation. Because the question is not only, can this operation be done? The better question is, will this operation help me live the way I want to live, with the risks my body can handle? That distinction matters. Many older adults say yes to surgery because they trust their doctor, because the pain is frustrating, because a scan looks serious, or because they feel they should not make trouble by asking too many questions. But surgery is not just a procedure on one body part. It is a full-body event. It can affect the heart, lungs, brain, muscles, medications, sleep, appetite, balance, and the ability to return home safely. This does not mean surgery is bad. It can relieve pain, remove disease, restore movement, and give someone years of better function. But the right decision is not always the fastest yes. Before you agree, 5 questions can change the conversation. They do not challenge your doctor's expertise. They help your doctor understand your goals, risks, and recovery needs. The 4th question is the one many people forget until after the operation. And the 5th may be the most important if you live alone, care for a spouse, or worry about independence. First, a brief safety boundary. If you have severe chest pain, trouble breathing, signs of stroke, major bleeding, a broken hip, or another emergency, this video is not a reason to delay urgent care. These questions are mainly for planned surgery, where there is time to think, compare options, and prepare. To understand why these questions matter, picture surgery like a major home renovation. The surgeon may be repairing one room, such as a knee, hip, spine, gallbladder, or artery. But during the renovation, the electricity, plumbing, heating, and entryways all have to work. In the body, that means circulation, breathing, memory, blood sugar, kidney function, medication balance, and muscle strength. At 35, the body often has a bigger reserve tank. At 75, that reserve may still be strong but smaller, especially with diabetes, heart disease, lung disease, kidney problems, anemia, memory changes, poor sleep, recent weight loss, or several medications. Medical teams sometimes call this physiologic reserve. In plain language, it means how much stress your body can absorb before things start to wobble. Surgery, anesthesia, pain, immobility, poor eating, new medicines, infection, and poor sleep can all use part of that reserve. That is why the best question is not, am I too old for surgery? Age alone is not the full story. A healthier 78-year-old may recover better than a frail 62-year-old. The real issue is whether the operation fits your condition, goals, support system, and recovery capacity. Question number 1. What exactly is the goal of this surgery, and what problem are we trying to solve? This sounds simple, but it is often where confusion begins. A viewer might hear, "Your scan shows severe arthritis. There is a narrowing, there is a blockage, or the joint is worn out." Those findings may be real, but the finding and the goal are not always the same thing. The goal might be to reduce pain, prevent a serious complication, improve walking, remove cancer, or stop bleeding. Each goal has a different standard for success. If the goal is pain relief, you need to ask, how much pain relief is realistic for someone like me? Not perfect pain relief, realistic pain relief. If the goal is better movement, ask, what activity are we trying to get back? Walking to the mailbox? Climbing stairs? Driving? Gardening? Sleeping without pain? Getting out of a chair without help? If the goal is preventing future harm, ask, what is the chance of that harm happening if I do not have surgery now? This helps separate a present problem from a possible future problem. Here is the hidden issue. Sometimes the scan looks worse than the person feels. Other times the person feels terrible, but the scan does not fully explain the symptoms. The body is not a photograph. It is a system. For example, an older adult may have back pain and a scan showing spinal narrowing. Surgery might help if the symptoms match the nerve pattern. But if the pain is mainly from muscle weakness, hip arthritis, poor balance, or neuropathy, the operation may not solve everything the person expects. That is why the first question should force clarity. You can ask it like this: if this surgery goes well, what specific symptom or limitation should improve, and what may not improve? That last part is powerful. What may not improve? A successful surgery can still leave some pain, stiffness, fatigue, numbness, or need for therapy. Knowing this before surgery prevents disappointment after surgery. Think of it like fixing a leaky roof. If water is coming from the roof, repair helps. But if the water is also coming from a cracked pipe inside the wall, fixing only the roof will not make the room dry. Before saying yes, write down your top 3 goals. Then ask, which of these goals is surgery most likely to help? That conversation changes the surgery from a vague promise into a measurable decision. And once the goal is clear, the next question becomes much sharper. Question number 2. What are my personal risks, not just the average risks? Many surgical conversations include general risks: bleeding, infection, blood clots, anesthesia problems, pain, scarring, and imperfect results. Those risks matter. But after 65, averages can hide the details that matter most. Your personal risk depends on more than your age. It depends on heart strength, lung function, kidney function, diabetes control, nutrition, muscle strength, balance, memory, medications, previous anesthesia reactions, and how independent you are before surgery. This is where many people underestimate the decision. They ask, is this surgery safe? A better question is, what are the most likely complications for me given my health and my medications? The word "me" matters. For one person, the biggest risk may be a heart problem. For another, it may be pneumonia because their lungs are weak. For another, it may be confusion after anesthesia. For another, it may be a fall during recovery. For another, it may be that pain medication causes constipation, dizziness, or oversedation. In older adults, complications do not always appear as dramatic symptoms. An infection may show up as confusion. Dehydration may show up as weakness. Medication side effects may show up as a fall. Poor sleep may look like memory decline. That is why personal risk is not just a number on a consent form. It is a pattern. Ask your surgeon or preoperative team, based on my medical history, what are the top 3 things you are most concerned about? Then pause and let them answer. You can also ask, is there anything about my health that we should improve before the operation? This is called optimization. In plain language, it means making the body more ready before the stress arrives. Sometimes that means improving anemia, adjusting blood sugar, reviewing blood thinners, improving nutrition, strengthening legs, checking the heart or lungs, or reducing certain medications that increase confusion risk. It is like preparing for a long trip. You do not wait until the car is halfway up the mountain to check the tires, oil, and brakes. A particularly important risk after 65 is delirium. Delirium means an acute change in attention, alertness, or thinking. It can happen after surgery, infection, hospitalization, certain medications, dehydration, poor sleep, or pain. It is not the same as ordinary forgetfulness. A person with delirium may be unusually sleepy, agitated, confused, suspicious, unable to follow conversation, or awake all night and drowsy all day. Families sometimes describe it as, they were not themselves. The practical question is not, will anesthesia ruin my brain? That is too broad and frightening. The better question is, what is my risk of confusion or delirium after surgery, and what can we do to reduce it? Risk reduction may include bringing hearing aids and glasses, avoiding unnecessary sedatives when possible, treating pain without oversedation, encouraging early movement, maintaining hydration, protecting sleep, and having familiar family support when allowed. Another personal risk is loss of function. This means the operation itself may go well, but the person struggles to regain walking, bathing, cooking, dressing, or managing medicines. For many older adults, independence is the real outcome. So ask, after this surgery, how likely is it that I will need rehabilitation, home health, a walker, extra help, or a temporary stay outside the home? Your team may not be able to give a perfect percentage, but the discussion reveals whether the recovery plan is realistic. And if your doctor seems rushed, ask for a preoperative visit, a geriatric assessment, or an anesthesia consultation when appropriate. You are not asking for a guarantee, you are asking for a map. Because once you understand personal risk, you are ready for the question that prevents many unnecessary regrets. Question number 3. What are my non-surgical options, and what happens if I wait? This question is not anti-surgery, it is pro-decision. Sometimes surgery is clearly the best option. Sometimes waiting is risky. Sometimes non-surgical care has already failed. But with pain, mobility problems, mild symptoms, or slowly progressing conditions, alternatives may be worth understanding. The point is not that alternatives are always better. The point is that you should know what you are comparing surgery against. Ask, what happens if I do not have surgery now? Then ask, what happens if I delay surgery for 3 months, 6 months, or 1 year? The answer may be very different depending on the condition. If there is cancer, severe blockage, repeated infection, unstable fracture, progressive nerve damage, or a dangerous abdominal problem, waiting may carry serious risks. But if the surgery is for chronic joint pain, some spine problems, hernia symptoms, gallstones without recent attacks, or certain quality of life concerns, the timing may be more flexible. This is where nuance matters. A non-surgical option may include physical therapy, targeted exercise, pain management, injections, medication adjustments, bracing, assistive devices, monitoring, or a second opinion. For some people, these options improve symptoms enough to delay surgery. For others, they confirm that surgery is the next reasonable step. Neither outcome is a failure. Here is a useful way to phrase it. What would we try if I were not ready for surgery yet? That question often opens the door to practical choices. But there is another side. Ask, is there a point where waiting would make surgery less successful or more dangerous? This is essential. Waiting too long with severe mobility limitation can lead to muscle loss, poor balance, isolation, and worse blood sugar control. A person may delay surgery because they fear it, but during the delay become weaker and less able to recover later. On the other hand, rushing into surgery before preparing the body can also lead to a harder recovery. So the question is not simply now or never. It is, what is the safest timing? Think of it like catching a train. Some trains leave urgently, others leave every hour. Others are worth postponing until you have packed properly. One mistake is assuming that elective means optional or unimportant. Elective simply means it can be scheduled. Some elective surgeries still matter a great deal for quality of life or long-term health. Another mistake is assuming that non-surgical means harmless. Long-term anti-inflammatory medicines can affect the stomach, kidneys, heart, or bleeding risk in some people. Injections have limits and may not be appropriate for everyone. Immobility has consequences. Uncontrolled pain has consequences. The goal is balanced comparison. Ask your doctor, can you compare the likely best case, typical case, and worst case for surgery versus waiting? The best case gives hope, the typical case gives realism, and the worst case gives preparedness. If the decision still feels unclear, ask whether a second opinion is reasonable. Now we reach the question many people forget until recovery begins. Question number 4. What will recovery actually require from me and from the people around me? This is where the picture often changes. Before surgery, many people focus on the operating room. After surgery, they realize the operating room was only the first chapter. Recovery is a job. It may involve wound care, medication schedules, breathing exercises, walking goals, physical therapy, follow-up visits, constipation prevention, transportation, bathing help, meals, and warning signs. For a 76-year-old who lives alone, cares for a partner, uses stairs, or already feels unsteady, this may be the difference between recovering safely and landing back in the hospital. Ask, how long before I can do my basic daily activities? Be specific. When can I get in and out of bed safely? When can I use the bathroom alone? When can I shower, climb stairs, drive, lift groceries, and manage medicines? These are not small questions. These are life questions. A common mistake is hearing, "You will recover in 6 weeks," without defining what recovery means. 6 weeks to what? 6 weeks until the incision heals? Until pain improves? Until driving is safe? Until walking is strong? Until fatigue improves? Until you can live alone again? Recovery has layers. The skin may heal before the muscles recover. Pain may improve before balance returns. Discharge may happen before the person is truly independent. That is why you need a home plan before the operation. Picture recovery like landing an airplane. The surgery may be the flight, but home is the runway. If the runway is dark, cluttered, icy, or too short, even a good flight can end badly. Before surgery, ask, "Will I need someone with me for the first 24 hours, first week, or longer?" Ask, "Should I arrange home health, outpatient therapy, or inpatient rehabilitation?" Ask, "What equipment should I have before I come home?" This might include a walker, raised toilet seat, shower chair, grab bars, medication organizer, easy meals, loose clothing, or a safe sleeping setup. Also ask, "What symptoms after surgery mean I should call the doctor, and what symptoms mean I should seek urgent help?" You want this written down. For many surgeries, warning signs may include fever, worsening redness, increasing swelling, uncontrolled pain, chest pain, shortness of breath, fainting, new confusion, one-sided weakness, calf pain or swelling, heavy bleeding, persistent vomiting, or signs of wound infection. The exact list depends on the operation. Do not rely on memory alone. Pain, anesthesia, poor sleep, and stress can make instructions harder to remember. A family member or friend should hear discharge instructions if possible. Medication planning is another part of recovery that deserves attention. Ask, "Which medications should I stop before surgery? Which should I continue? And when do I restart them?" This is especially important for blood thinners, diabetes medicines, blood pressure medicines, sleep medicines, sedatives, supplements, anti-inflammatory drugs, and anything that affects bleeding, blood sugar, or alertness. Do not make these changes on your own. The timing can be very specific. Also ask, "What is the pain plan, and how will we avoid oversedation, constipation, falls, and confusion?" Pain control matters because severe pain can slow breathing, prevent walking, and disrupt sleep. But too much sedation can increase falls, confusion, and breathing problems. The right plan balances comfort with safety. This question may feel practical, not dramatic, but it may be the question that protects your independence. Because a surgery decision is not complete until the recovery plan is complete. And that leads to the final question, the one that turns a medical decision into a personal decision. Question number 5. If things do not go as expected, what choices would I want made? Most people avoid this question because it feels uncomfortable. But asking it before surgery is not pessimism. It is preparation. When everything goes well, this question may never matter. But if complications happen, decisions may need to be made quickly. Families can feel overwhelmed if they do not know what the patient would have wanted. Ask your surgeon, "If I have a complication, what are the most likely scenarios?" Then ask, "What would the next steps be?" For some operations, a complication may mean antibiotics, a longer hospital stay, a second procedure, intensive care, a breathing machine, rehabilitation, or months of recovery. For many people, these are temporary supports. For others, they may lead to choices about how aggressive treatment should be. This does not mean you should fear every possibility. It means your values should be known before stress arrives. A useful question is, what outcome would make this surgery worth it for me, and what outcome would not? For one person, living with less pain is worth a long recovery. For another, avoiding a nursing facility is the top priority. For another, staying mentally clear matters more than walking farther. For another, living long enough to attend a family event is the main goal. There is no single correct answer. There is only the answer that fits your life. This is where advanced care planning matters. In plain language, that means choosing who can speak for you if you cannot speak for yourself, and writing down your preferences about major medical decisions. The person you choose should not simply be the closest relative. It should be someone who can stay calm, understand your values, communicate with doctors, and make decisions you would agree with, even if the decision is emotionally hard. Ask, who should be my medical decision maker if I am temporarily unable to decide? Then tell that person what matters to you. You might say, if I can recover and return home, I would want aggressive treatment. Or, I am willing to go through rehabilitation, but I do not want months of treatment with no realistic chance of returning to the life I value. These conversations can be difficult, but they are a gift to your family. They reduce guessing, reduce guilt, and help doctors match treatment to the person, not just the disease. This final question also includes logistics. Ask, what costs, rehabilitation coverage, transportation, caregiver needs, or follow-up appointments should I plan for? A surgery may be medically successful, but personally stressful if the support plan is missing. Before saying yes, bring the conversation back to your real life. Can I recover in my home? Who will drive me? Who will check on me? What if I need more help than expected? These questions are not signs of weakness. They are signs of wisdom. Now let's turn the 5 questions into a simple action plan you can use before your next appointment. Step 1. Write your goals in plain language. Do not write, I want the surgery to work. Write what working means. I want to walk for 10 minutes. I want to reduce pain at night. I want to avoid emergency hospitalization. I want to keep living independently. Bring that list to your appointment. Step 2. Ask for the goal, the personal risks, and the alternatives in the same conversation. What is the exact goal? What are my personal risks? What happens if I wait or try something else first? If you only ask one of them, the decision may be incomplete. Step 3. Build the recovery plan before the surgery date. Do not wait until discharge. Ask about therapy, equipment, transportation, home safety, medications, wound care, warning signs, and who should stay with you. If you live alone, care for someone else, have stairs, poor vision, memory concerns, or limited money for extra help, say that clearly. Your team cannot plan around facts they do not know. Step 4. Review your medications and brain safety plan. Bring a complete list of prescription medicines, over-the-counter medicines, vitamins, sleep aids, pain relievers, and supplements. Include doses if you can. Ask about anesthesia options, delirium risk, sleep, glasses, hearing aids, hydration, pain control, and early movement. The goal is not to eliminate every risk, it is to reduce avoidable risk. Step 5. Choose your decision maker and discuss your values. This may be the most loving preparation you can do. Tell one trusted person what outcomes matter most to you. Ask how to document that choice properly in your location and medical system. Then make sure your surgical team knows who that person is. Here is the central idea. After 65, the best surgery decision is not based only on whether the operation can be performed. It is based on whether the operation's goal, risk, timing, recovery plan, and backup plan fit the person who will live with the result. A good question can prevent 2 opposite problems: unnecessary fear when surgery is likely to help, and unnecessary treatment when the benefit is unclear, risks are underestimated, or the recovery plan is missing. So before you say yes, do not ask only, is surgery safe? Ask, what is the goal? What are my personal risks? What are my alternatives and timing options? What will recovery truly require? And what choices would I want made if things do not go as expected? If this video helped you think more clearly about a surgery decision, subscribe for calm, practical health explanations for older adults and families. And consider sharing this with someone who has an operation coming up, because the right question before surgery can sometimes change the entire recovery afterward. The goal is not to fear surgery. The goal is to walk into the decision with your eyes open, your support ready, and your own life at the center of the plan.